So I'm presenting a fairly straightforward case, not much debate in this. In the sense, it's a 42-year-old lady who's complaining of decreased vision in the left eye for the past 9 months. She also gives history of recurrent episodes of pain and irritation, and has been using various drops for past few years now. The vision in the left eye was hand movement. In the right eye had 6/6 vision. There's a history of cataract surgery done 1 year ago. And the other relevant past history is she gives a history of Steven Johnson syndrome attack 8 years ago. And this is the clinical picture. You can see there is there's a mature cataract at the background with significant corneal opacity, vascularization. I'm sorry, I don't have a picture with the staining done, fluorescein staining, but she also had numerous punctate epithelial erosions, small PEs diffusely around the cornea. And she has been using lubricant eye drops. Should I continue and finish the case, sir?
No,
Or should I?
finish off the case,
Right,
Shreyas.
sir. Right, sir. So the other very important thing in patients with Steven Johnson syndrome, the other eye has already undergone a cataract surgery. She essentially came for a cataract surgery in this eye. But it is very important that we stabilize the ocular surface before going ahead with the cataract surgery. And
Absolutely.
this is how her lids looked. If you can see, there is a significant amount of roughness. There's all keratinization. There's basically migration of the stratified squamous epithelium from the anterior lid margin posteriorly, and has now led to deposition of some keratin. So unless we evert the lid, we might even miss this because the margins otherwise don't look as unhealthy as you would, as it might be in certain other Steven Johnson syndrome patients. So this is the surgical video. So what I first did was to first do lid mucous membrane grafting. So this entire area, which is rough, can constantly erode on the cornea and cause recurrent erosions to happen. And if we just do a plain cataract surgery and the patient is on postoperatively only on steroids, then there is a very high risk of epithelial breakdown, corneal melt, and even perforation. So it's extremely important we take care of this surface. So essentially, you're trying to remove the entire lid margin posterior to the gray line, involving the meibomian glands, and then some portion of the tarsal conjunctiva, which is also keratinized. And then you take a thin layer of lip mucosa, which is then anchored onto the lid margin. You're essentially replacing the lid margin, replacing it from a rough surface to a very smooth lip mucosal surface. And these vicryl sutures are placed to anchor the mucosa here. And essentially, you have to take bites into the tarsus as well, because that's from where the vascularity is going to come in. And this usually takes up very well. These are stay sutures which are being removed, and the same procedure is done in the lower lip as well. So once this is done and the surface stabilizes, and you can see here the patient's the congestion is significantly reduced. There is no punctate erosions now, and there is a very nice lip mucosa. So after this, once this has healed after 6 weeks, I take up the patient for cataract surgery now. And there is still, the fornices are not completely formed, so you will not be able to place a speculum. So I take these regular traction sutures and then go ahead with the cataract surgery. Obviously, staining is necessary. Retroillumination, chandelier illumination may not work in this case because of the total cataract. Can be used in the later stages of the surgery, but at least at this point of time, the white cataract itself will give you sufficient visibility to do the rhexis. One mistake which I did here was to finish the rhexis under the area of opacification. So this made visibility a little poor at the area where I was not sure whether the rhexis was completed. So after making the incision, I went ahead with the rhexis forceps and ensured that I had completed the rhexis before I proceeded. Gentle hydro and then ensuring that the nucleus is rotating is important. Go ahead with the regular chopping mechanism which you normally use. I prefer doing a direct chop. And this is a moderately dense cataract. As you can see here, you have to do a multi-level chop to ensure the pieces are completely separated. Yes, there is an opacity which is slightly obstructing your view, but you can always tilt the eye towards one side so that your phaco probe is slightly superior to the opacity, and you can actually visualize where your phaco tip is when you're doing your chopping maneuvers. During emulsification as well, it's important that you're careful, you're able to visualize your phaco tip, and keep putting in viscoelastics every once in a while, as there is a natural tendency for you to slightly bring your phaco probe a little more anterior in these cases when you're not able to visualize very clearly the rexus and the PC. And once this phaco has been done, I prefer a 3-piece lens in most of these cases, especially if you're anticipating a rexus runoff in these kinds of total cataract. Always in these compromised corneas, it's good to place a suture. A lot of us might be wondering, there is a significant opacity. Is this really going to help? But in these Steven-Johnson syndrome patients, where keratoplasty is an absolute no-no, you can't do any form of keratoplasty. This gives them a great, rejuvenating their surface with a mucous membrane graft, and then subsequently a cataract surgery. And this patient subsequently was fitted with a scleral contact lens and had a vision of 612 with scleral contact lenses. So, which is a very acceptable outcome in these kind of patients. So, to sum up, thank you, sir.
Yeah. You want to sum up?
To sum up, yes, sir. I had a next slide. Yeah. To sum up, so you stabilize the ocular surface first. Try to form the fornices to the extent which allows scleral lens fitting subsequently. Yes, you may not have a very deep fornix, but still you need enough of a fornix so that scleral fitting can be done. So any symblifera which is extending anteriorly needs to be addressed. And then staged cataract surgery using assisted illumination can be done. Of course, no corneal grafts in patients with SGS or OCP. Thank you so much for it.
Absolutely. Brilliant, Shreyas. You are really given a fantastic message of stabilizing the ocular surface in such situations, and then going ahead with the cataract surgery. Don't hurry up in doing a cataract surgery. You'll end up in a mess. You are really better than the best. You know who's the best. Okay, you are better than that guy. That guy is right in the panel here. And we'll ask one by one the panelists quick comments. I'm sure everybody has got agree with the way Shreyas has handled this case.
Yeah, it's an excellent job, stepwise, very matured way of approaching a patient. Beautifully done, and the outcome is excellent. Very nice. Congratulations.
Thank you, sir.
Very nice.
Thank you. RDR, sir. Ramamurthy.
Happy to say very nice surgery, Shreyas. I mean, the learning point for everybody is, that how do we stabilize the ocular surface, especially the lid. The lid is a kind of a ignored area. I think looking at that lid and correcting that irregularity also is very, very important. I think that's an important take-home message, I think, from this talk. Thank you, Shreyas.
Yeah. Yes, I was wondering, I wanted to ask you just 2 questions. One is, you used a buccal mucosa in this case?
No, sir, lip mucosa, sir. Because for the lid, if we use buccal mucosa, it's very thick, sir. So it becomes very bulky and cosmetically not very acceptable. So lip mucosa works better for the lid. If I'm doing for the ocular surface, I prefer a buccal mucosa.
Yeah, that's right. We have done a lot of cases with the buccal mucosa, Steven-Johnson syndrome.
Yes.
I just have a question for...
I was wondering whether you use the endo illuminator, where we can use the endo illuminator to do the capsulorhexis.
Yes,
and
sir.
Of course, the dye was there for you, but also during the phacoemulsification, the endo illuminator gives you a better, view. Ask the old endo illuminator, or even a chandelier would have been better. Ramamurthy, you have anything to say?
Yeah, one comment is like he did during phaco. If you have a problem during the capsulorhexis also, tilting the eye a little bit sometimes allows you better visualization and complete the capsulorhexis. And another question I have for Shreyas is that you simply mentioned that the patient had very good outcome after cataract surgery in the fellow eye at 6/6 visual acuity. I thought mostly these SJS cases are bilateral. How is it that the other eye did so well?
Actually, that's something I wanted to highlight as a take-home message. I missed it. Very often it is the involvement is bilateral but can be very asymmetric. Now this patient, fortunately for her, in the right eye had fairly the lids were quite all right, though there was minimal keratinization. It was restricted to the lateral aspect, and therefore the cornea was not being eroded. and the patient was quite comfortable, and just with a plain cataract surgery, she was doing very well. Whereas in the left eye, the keratinization was right through in the entire lid margin, and therefore that had to be addressed first. So it was bilateral presentation, but very asymmetric.
Asymmetrical, which is not uncommon in patients.
Not uncommon.
Yeah, but Rajshekar?
Already, the cornea had some punctate erosions, as was pointed out. I was just thinking whether that lip mucosa could have been stuck with glue than to suture with the vicryl, and or did you use a lid stay suture and protected the cornea, or that immediate post-op, like 21 days of when the sutures were there?
I just place a BCL.
Rubbing on the cornea, I'm sure.
Yes. No, I just place a bandage contact lens, sir. That usually is sufficient. And these sutures generally, because they are reverted, they are quite posterior, sir, the vicryl sutures. So they won't necessarily erode. But yes, I always place a bandage contact lens, and that works, sir. With regards to the punctate erosions, that was diffuse, and with the lip mucosa, once it took up, it was quite stable, sir. So after that, we didn't have much punctate erosions after that.
Okay. And to hold on to a scleral lens, you said you maintained the surface and opened up the surface. What did you do for that?
Just during the procedure, I also did a Symblifera release, which was coming from the lid, and to the extent possible, sir. And immediately that raw surface is being replaced by your lip mucosa, so the Symblifera does not form again, and that is usually sufficient, sir.
Fine, nicely
very
done.
Nice way of managing that, and a very complex case, and ultimately you've done it so well, Shreyas. Hats off to you. Congratulations. My compliments to you for the wonderful presentation.